So, hello once again. My name is Violet Aswa Akek. I'm a lecturer of pediatrics at the Kenya Medical Training College in the Department of Clinical Medicine. I want to welcome you all to today's tutorial. This tutorial is made for my clinical medicine students with love. So today we are going to be talking about oxygen administration. Welcome. A few introductory statements we shall make. Number one is to understand that oxygen therapy is a treatment that provides a patient with extra oxygen to breathe in. Anytime you're giving a patient extra oxygen, it means you're providing oxygen therapy. Sometimes it is also referred to as supplemental oxygen or oxygen supplementation. It is usually an indication in any child who has hypoxemia or is at risk of developing hypoxemia as a means of preventing it. Accordingly, it is supposed to be prescribed just like the way you prescribe any other therapy or medication. Oxygen should be fully prescribed. That is to say, if you are going to be writing a treatment plan for a patient, you don't just write the word oxygen and leave it at that. You also don't say oxygen when necessary. There is nobody who is coming to decide when it is necessary. It is you as a clinician who must decide when is it necessary. And so you must prescribe it the same way you prescribe an antibiotic, the same way you prescribe any other medication. And therefore, you must also decide when to stop it. So what do we mean by hypoxemia? Hypoxemia only refers to oxygen saturation of less than 90%. And this state can be assessed clinically by clinical signs. So we will have signs that suggest hypoxemia because the child will be having, they'll be having compensatory mechanisms in place. And so when they're compensating, we will see certain signs that will suggest or help us know that this child is compensating. And the only reason they could be compensating is because their oxygen saturation is not optimal. Hypoxemia can also be assessed by use of a gadget known as a pulse oximeter. The process is known as pulse oximetry. I'm sure you have all seen a pulse oximeter. Oxygen saturation can also be measured or assessed by use of blood gas analysis. And this is using mostly arterial blood. Pretty invasive, but it's also one of the means by which we can assess hypoxia. It often presents in sick children, so it's a common thing to see or to observe. And when it is present, it is a major risk factor for death. It doesn't matter what diagnosis the child is or whatever is having or whatever the child is being treated for. If and when hypoxia shows up, that is a risk marker for death. So what are some of the signs that indicate the need for oxygen supplementation or oxygen therapy? If you see central cyanosis in a child, that child needs oxygen. They are seriously or severely hypoxiated. And remember we said for central cyanosis, it is preferable to look at the gums and under the tongue. That is the best site to look for central cyanosis. Head nodding, that is a sign of respiratory distress, increased work of breathing. Nasal flaring, the same. Grunting, commonly observed in infants, usually expiratory in nature. And I think you remember when we did essential clinical signs, we were able to appreciate all these signs. Severe chest wall indrawing, So we say severe chest wall, lower chest wall indrawing when we are referring to the young infant. But when you are referring to the older child, chest wall indrawing is adequate, it is sufficient. But then when you're referring to the young infant, then you must be referring to severe lower chest wall indrawing. This is because they have a soft chest wall, and so sometimes it may withdraw even when they're not seriously hypoxiated. A child may not have the obvious signs of respiratory distress, but may have a very high respiratory rate. If a child has a respiratory rate of more than 70 breaths per minute, even if they don't have cyanosis, they don't have chest wall indrawing, they aren't grunting, they don't have nasal flaring, that alone is an indication for oxygen therapy. Pulse oximetry showing oxygen saturation of less than 90% is an express indication for oxygen therapy. A child who is convulsing and a child who has just been resuscitated. All these are indications for oxygen therapy. So, when we are talking about administering oxygen, what must you have? Number one, you need an oxygen source. Besides having an oxygen source, you must have a way of getting that oxygen from its source to the patient. So some of the oxygen sources are piped oxygen. Oxygen can be piped. You can obtain oxygen from a cylinder, and you can also obtain oxygen from an oxygen concentrator. The accessories that you may need include a nasal cannula, also known as a nasal prong, nasal catheters, oxygen masks, and then we have the non-rebreather masks, also commonly referred to as oxygen mask with a reservoir bag or a non-rebreather bag. All those words or statements will usually mean the same thing. So these are some of the things that you will require. If you're going to be working in a hospital setting, maybe you're setting up a pediatric unit, you're going to require all these things in order to support children when they require oxygen. And then, of course, you require a reservoir tubing. I have compiled a few images for you to see. This is an example of piped oxygen. I'm sure we are all familiar with this kind of setting. Those of you who have gone through Kenyatta National Hospital, you have seen this. And any other major hospital, referral hospitals, you have seen oxygen that is piped. It is usually fixed on the wall like this, coming from an oxygen plant. These are some images of oxygen cylinders. So this is how it looks like. When we get time and we go to the skills lab, you will be able to see how it is operated, how it is mounted. Also, when you're rotating in the pediatric wards during your clinical rotation sessions, you should be able to see some of these cylinders and know how they are used. These are examples of how oxygen concentrators look like. This big one over here is a stationary type, stationary kind of oxygen concentrator. And so this one will usually be found just stationed in the ward, in the pediatric ward or any other place. And then we have these other smaller ones which are portable. These are very good because you can use them when you're referring a patient who requires to be on oxygen while they are traveling to their next level of care and when they are being referred. So it's good to familiarize yourself with how they look like so that when you see them and then you can be able to be shown how they are operated as you rotate in the wards. These are some of the accessories that we have mentioned. This one here, let me show you. I'll use this color. So this here is the nasal prongs. Anytime you watch a movie in the TV or whatever, you will usually see anybody who gets sick, they usually get a nasal prong or nasal cannula. Now these are the prongs. This is the area that goes through the nostrils. Okay, and this one joins to the oxygen tubing. This is a nasal catheter. Nasal catheter is slightly different from the nasal prong. So mostly right now, what is really being used commonly will be a nasal prong and the non-rebreather mask, very common. But we also have the nasal catheter. So when you have a child that requires oxygen therapy, what should you do? The first thing to do is to start giving oxygen at accurate and safe levels. So when we shall be looking at how to prescribe oxygen, you will be able to understand what are the safe levels of administering oxygen to depending on the age of the child, and also how to accurately prescribe the same. It's important to always document the flow rate and delivery device. Like I told you, don't just prescribe oxygen by writing the word oxygen and leave it hanging like that. When you're prescribing oxygen, you must say oxygen by what gadget or what device, at what flow rate, for how long, when should the child be observed or monitored, how is the monitoring going to be done. So you must document all these things. Very important. Then monitoring the frequency and target oxygen saturation is very important as part of the oxygen prescription. That is what I'm just saying, that when you prescribe, you must say you are prescribing oxygen to be delivered via which type of device, what flow rate should be used, how frequently should the child be monitored, and in your mind, you must know what is the target oxygen saturation that you are looking at. So what are some of the recommended target saturations? For neonates, it is recommended that the target usually be between 91 and 95%. You do not want them to get oxygen toxicity. For older children, it is recommended between 90 and 95%. And then those children who have just gone through resuscitation, 94 to 98%. Now, when you're prescribing and administering oxygen, you also need to titrate the oxygen against the saturation. So you're titrating the ventilation or the delivery against the saturation. So every 15 to 30 minutes, you need to adjust your oxygen flow rate by 0.5 liters per minute until such a time that you have reached your target saturation. For example, if you are administering oxygen in a child who is 3 years old, perhaps they came in with oxygen saturation of maybe 85%. Okay, so you start off maybe with high flow oxygen or even low flow oxygen, standard flow rather. So you give them oxygen by nasal prongs at 2 liters or 3 liters per minute. Every 15 to 30 minutes, you should be observing and monitoring them to see if you are achieving, how far away you are from achieving your desired oxygen saturation. And so your adjustments will be by 0.5 liters per minute. Having said that, then how do we prescribe oxygen? Let's start by prescribing oxygen that is to be delivered via nasal prongs. We have a standard flow rates, and then we have high flow rates. So when we are talking about standard flow rates using nasal prongs, this is how you prescribe. For neonates, it will be between 0.5 and 1 liter per minute flow rate. For infants, it will be between 1 and 2 liters per minute. So you see, from the neonate to the infant, we are doubling the flow rate. Okay? It's an easy way to remember. And then for the bigger child, it is 1 to 4 liters per minute. That is for the standard flow rate. How about the high flow rate? For the preterm neonate, it will be 1 liter per minute flow rate. For the term neonate, it will be 2 liters per minute. And for the older infant, it will be 4 liters per minute, and the bigger child, 4 to 8 liters per minute. So please note that when we come to the high flow rates, using a nasal prong, we break down the neonate to the term and the preterm. So the term receives 2 liters per minute and the preterm receives 1 liter per minute. That delivers high flow oxygen. What is the fraction of inspired oxygen expected when you deliver oxygen by nasal prongs this way? So when you use the standard flow rates, you're able to deliver 35% of oxygen to the patient. And when you use the high flow rates, you're able to deliver 50% of oxygen to the patient. Please remember, anytime you prescribe high flow rates to a patient, you must also remember to humidify the oxygen. Okay? We are still talking about how to prescribe oxygen. Nasal catheter. For nasal catheter, in neonates, it is not recommended. Neonates are better off using the nasal prongs, not nasal catheter. So we don't recommend the use of nasal catheters in neonates. However, in infants and children, the flow rate is usually 1 to 2 liters per minute. The expected fraction of inspired oxygen when you're using a nasal catheter is usually about 40% of oxygen to the patient. These are important things for you to remember so that you know when you're prescribing what you're giving, to what extent, and what do you expect. Still talking about prescription of oxygen. When you're using face mask with a reservoir bag or the non-rebreather bag, the flow rate is usually 10 to 15 liters per minute, irrespective of the age of the child. The bag should usually be fully inflated. It should not be collapsed. It shouldn't be deflated. It should not collapse. It should be fully inflated. That way, the patient is not rebreathing carbon dioxide, okay? So it is important that the bag is full while the patient is receiving oxygen. The fraction of inspired oxygen by this method of flow rate is 80 to 95% of oxygen. Actually, it is the highest possible that you can give. That is the non-invasive delivery modes. So these are some of the pictures that demonstrate what we have been talking about. This one here is the nasal prong. This is the nasal catheter. I'm sure most of you are very much familiar with the nasal prongs. And this is a picture of a child receiving oxygen by the non-rebreather mask. So you can see the mask, or the bag rather, is full. It is nicely inflated so that this child is not rebreathing carbon dioxide, or rather the oxygen he's getting is not diluted with carbon dioxide. So you have done your prescription. First of all, you have checked the signs of the child. You have seen that they are requiring oxygen therapy. You have done your prescription nicely. The flow rate, what delivery gadget or device you're going to be using, you know exactly what you're giving and what you're expecting, what fractions of inspired oxygen that you are giving. So what happens once you have reached your target saturation? Remember the target saturations we talked about, the neonate, the child, and the child who has just been resuscitated. Okay? So what do? Once the target or desired oxygen saturation has been achieved, you maintain that flow rate. You maintain oxygen therapy or administration at that flow rate at which you have achieved the saturation, the desired saturation. And then you monitor the oxygen saturation and the work of breathing. By work of breathing, I also like to make it easy by letting you know that you are looking for signs of respiratory distress. Because if the work of breathing is high or more, the child is putting in a lot of work to breathe, the respiratory rate is high, they're using accessory muscles of respiration, they're having chest wall indrawing, they are cyanosed, meaning that their oxygen saturation is compromised. This is a child who needs oxygen. And so, even if you have achieved your target oxygen saturation, you maintain it at that. You maintain the flow rate at that level. But you will still continue monitoring this child to make sure that the oxygen saturation is still good within the ranges that you want. And also, you want to make sure that this child is not putting in a lot of work to breathe. They are not in distress. And at the same time, you treat the underlying cause. Remember, hypoxia doesn't just occur on its own, it will usually be caused by something. So, once all these things are going on, then you now need to check if the patient is stable. That is what we mean by monitoring. So you'll keep checking the oxygen saturation, which should be above 90%. You need to look if there are any signs of increased work of breathing and if there are any emergency signs. If the answer is no to these things, then you refer the patient to or for advanced care, which means you have checked your patient's stability and you're not happy with the oxygen saturation. It is not more than 90. You have checked and you find the child is having increased work of breathing. You have checked and you have found they're having emergency signs. If that is the case, then you refer the child for advanced care. Advanced care in this case may mean a high flow nasal cannula or CPAP or even mechanical ventilation. And of course, maybe whatever you're treating is not the correct diagnosis. So there may be need to review the diagnosis. If the answer to the patient stability is yes, then you make other decisions. If the patient is stable at the flow rate where you achieved your desired oxygen saturation, then you need to start weaning off oxygen. And again, just like we were in tapering it up or increasing it steadily when we started administering oxygen, again, when you're weaning it off, you also taper it off slowly. The same rate, 0.5 liters per minute every 30 minutes. So you'll be bringing down the oxygen flow rate by 0.5 liters per minute every 30 minutes. And at the same time, you'll be monitoring the oxygen saturation as well as the work of breathing. Once you have completely stopped it, then you must come back and assess the child an hour later, just to be sure that they are not desaturating again. They are not getting hypoxic again, because sometimes desaturation can occur. If you're happy that your child is able to maintain an oxygen saturation of more than 90% at room temperature without any increased work of breathing for more than a day in the ward, then you can discharge that child quite safely. Having said that, let's pay some attention to the preterm. How to support the respiration of a preterm baby who is otherwise breathing spontaneously and has good tone, which means they do not have any compromised CNS functionality. So we are going to be looking at the gestational age and also the birth weight. and seeing what is the recommendation for that particular gestational age and birth weight. So, if the gestational age is below 28 weeks or the weight is less than 1 kilogram, the recommendation is you put them on oxygen at 1 liter per minute using nasal prongs. Remember, we said nasal prongs are the preferred means of administering oxygen to the young infant, not nasal catheter. If the gestational age is more than 30 weeks and the weight is more than 1.3 kilograms, the recommendation is that you put them on oxygen at 1 liter per minute using nasal prongs and then prophylactic CPAP. And we shall talk about CPAP a little bit later. If the gestational age is now between what we have already said, between 28 and 30 weeks, and or the weight is between 1 kilo and 1.3, the recommendation is you put them on oxygen, standard flow rate, and then you put them on skin-to-skin contact, that is kangaroo mother care, because they're fairly stable. And then you assess them after 15 minutes. And if there are any signs of respiratory distress, then you administer rescue CPAP. So there's a slide that repeats this in details when we're talking about what should you do in the delivery room. Okay, so this is CPAP. CPAP is a short form for continuous positive airway pressure. CPAP means continuous, where is my marker? Continuous, P positive, A airway, P pressure. So let's see how to use this in a newborn. So I have identified some good video tutorials that I would like you to watch at this point before you continue, because it will make it very easy for you to understand. There is this one, which is about 9 minutes and a half, and then there's this short one of 2 minutes. These links are also in the description box below, so you can click on them and watch before you proceed. So this is important to remember, that CPAP is not recommended for neonates with birth weight of less than 1 kilo and an APGAR score of less than 4 at 5 minutes. Remember the APGAR scores that we do at 1 minute, at 5 minutes, and at 10 minutes, and we continue depending on how the clinical picture. So any newborn who is presenting with an APGAR score of less than 4 at 5 minutes is not recommended for CPAP. Also, CPAP should be deferred in neonates with number 1, uncontrolled seizures, and also neonates with apnea or gasping respiration. What should you therefore do at birth or in the delivery room? For babies with spontaneous respiration and a heart rate of more than 100 beats per minute, whether or not they have been resuscitated, we divide them into 3 categories. The first category, like you already seen, is 28 weeks, less than 28 weeks, or less than 100 grams. The second category is the in-between, 28 to 30 weeks, or weight of 1 kilo to 1.3. That is 1,000 grams to 1,300 grams. And then we had the third category, which is the preterm, who is usually more than 30 weeks and also more than 1,300 grams. So pay attention to these categorizations. If you're dealing with a preterm who is less than 28 weeks and less than 1 kilo, these are babies that you should not use CPAP on, remember? So you put them on oxygen. This will be high flow, 1 liter per minute via nasal prong. If you're dealing with a preterm between 28 and 30 weeks or weight 1 to 1.3 kilos, then you initiate prophylactic CPAP in the delivery room, or you can put them on oxygen at 1 liter per minute via nasal prongs and then transfer them to newborn unit for where they can now be initiated on CPAP. If you are dealing with a preterm who is more than 30 weeks gestation or has a birth weight of more than 1.3 kilos, you need to assess them. These are fairly big. You need to assess them for any one of these signs that we are going to see. Respiratory rate, if it is more than 60, if they're grunting, if they have nasal flaring, if they have a sternal intercostal recession, or if they have severe chest wall indrawing. They don't have to have more than one. Any one of these signs. If there is yes to any one of these signs, then you need to transfer them to what we refer to as Category A newborn unit. Category A newborn unit in Kenya is the newborn unit for critically ill newborns. While there, this newborn should be put on oxygen at 1 liter per minute via nasal prongs. They should be initiated on feeding immediately. Most likely, if they're not able to suck, they should be fed by nasogastric tube and on expressed breast milk. But depending on the indication, again, now you need to make reference to what you've already learned in prematurity, how to take care of a preterm, the feeding. There are those preterms in whom we start on day 1 with 10% dextrose on day 1, and then we have those preterms in whom we can begin with breast milk on day 1. So you need to do that according to the indication. Must keep them warm in order to prevent hypothermia and also prevent hypoglycemia. If they are having any sign of infection, they should be started on antibiotics immediately. And then do not disturb them too much. There should be minimal handling, because also too much handling and many people can also transmit infections. And then if they're newly born, then they need to be put on vitamin K, cord care and eye care, the way it is recommended in the essential newborn care protocols. Now, once all that has been initiated, this newborn needs to be reassessed at 15 minutes. You need to check for the oxygen saturation, which we want it to be at 90 to 95% with no distress. If that is the case, then you initiate CPAP. What is the setting? You have watched the video, so now you will understand all these things that are in this box. The setting is fraction of inspired oxygen should be at 50%. The total flow should be at 6 liters per minute. The oxygen flow should be at 3 liters per minute, and the CPAP water level should be at about 6 centimeters. So, the fraction of inspired oxygen is adjusted against the oxygen saturation, which means the lower the oxygen saturation, the higher the fraction of inspired oxygen should be adjusted. Then, the fraction of inspired oxygen is adjusted by 20% every minute until the oxygen saturation is at between 90 and 95%. So you will titrate the oxygen flow rate up or down by 0.5 liters per minute every minute. If the oxygen saturation is continuously below 90, which is not good, then you increase the oxygen. And if it is continuously above 95, then you decrease the oxygen. Because remember, the preferred or recommended saturation for the neonate is between 90 and 95% oxygen saturation. So if it is below 90, you increase. If it is above 95, you should decrease accordingly. So at what point do you decide to stop the CPAP and how do you do it? So when the oxygen saturation is constantly above 95% and there are no signs of respiratory distress, then that is an indication that you need to decrease the fraction of inspired oxygen in order to achieve the recommended oxygen saturation of between 90 and 95%. And usually the oxygen is weaned off before the pressure. That is the sequence. Please do not forget the family-centered care. And this you will usually do at the beginning before you start any procedure, before you start any administration or any therapeutic maneuvers or interventions. Usually remember the family-centered care. In family-centered care, we are saying that you need to talk to the mother or the parents about the need to start their baby on oxygen therapy. You need to let them know and emphasize that this therapy you're going to institute is going to improve their baby's breathing. And also you need to explain to them that it's going to be safe, that their baby is not going to be hurt in any way, and that you're going to be monitoring every step of the way, that you're going to be making adjustments every step of the way so that they don't get too worried when they see you on and off. We are saying adjust this and that every 1 minute, every 15 minutes, that can send anxiety into the caregiver or the parent. And so it's very important that you explain this to them. And of course, you need to address any concerns they may have, any questions they may have, you need to answer them adequately. With that, we have come to the end of our small lecture on oxygen administration for children, both the young infant, the preterm, and also the older child. Please feel free to ask me questions, put them in the comment section, or we can just discuss them in class when we meet. Reference materials have been the MOH pediatric protocols and also the comprehensive newborn care protocols. Thank you and see you next time.